in pursuit of health and wisdom. Sapio with Buck Joffrey.
Welcome back to Sapio with Buck Joffrey. And this week, I'm going to do something a little interesting. Hopefully, you'll be able to follow this. I find this very fascinating, so I'm just trying to figure out how to share this with you. But what we're going to do is talk about the Boston Heart Cholesterol Balance Test, something that you might consider getting. I had this done. What we're going to do is I have made my results available to you. If you look in the show notes, you should find that, or you should find a link to it. You'll kind of find out where I'm at. And I think it's really interesting, and I'm glad I'm on top of this stuff. What is the importance of this test? Well, as a review, cholesterol metabolism plays a big role in cardiovascular health. We've talked about that a bunch of times, even recently, about the relevance of ApoB, LDL cholesterol, those kinds of things in the natural history of atherosclerosis. And so, I think one of the ideas is, generally speaking, high cholesterol is required. It is necessary, although maybe not sufficient, in order to have developed problems with atherosclerosis. But what people, I think, don't really know, and frankly, I didn't really realize this until, about a year ago, is that most of us don't get the majority of our cholesterol from food, okay? In the vast majority of cases, people absorb very, very little cholesterol from food. In fact, I think about 30% of people have material absorption from food, whereas 70% only really are affected primarily by the cholesterol they produce in their liver. Okay, so that's actually a really, really important point, because it will help you kind of understand like what medications are going to work for you. Because if you're on a statin, statins are things that help stop you from producing too much cholesterol. And if you happen to be a super high absorber and have a high cholesterol diet, it's not going to necessarily help you, and vice versa. You might not be an absorber at all, which many people don't absorb much cholesterol at all from their diet. And you may be one of those people who, just produces cholesterol. In that case, a medication like Zetia, which is one of the major medications for cholesterol, is not going to be useful for you, because the way Zetia works is by preventing absorption of cholesterol. Bottom line is, this test, this Boston Heart Cholesterol Balance Test, helps us to kind of wade through that and provides insight into whether we are more absorbers, whether we are more producers, and, if our cholesterol is high, what is the best way to combat that? And just to reiterate a little bit, cholesterol is an essential lipid. We know that, involved in membrane integrity, hormone synthesis, bile acid production. It's really important, right? It's not like, we need cholesterol to live, right? It's, as I mentioned, it's produced by the liver, but it's also absorbed to varying degrees from dietary sources. We'll give you a little bit of detail here in terms of, production, the body's production, endogenous production. The liver synthesizes cholesterol through a multi-step process known as the mevalonate pathway, okay? This is going to start getting important when I would encourage you to, if you have a chance, to pull up Boston Heart Balance Test in the link provided, or, if it's in the show notes, whatever my producer decided to do, it will be available. If you're watching this on YouTube, it'll be a lot easier. It'll be up on the screen. That mevalonate pathway, the key intermediates in this pathway include, I don't know exactly how to pronounce these words, but lathosterol and desmosterol, okay? Those are the key intermediates. In other words, on your way to production of cholesterol, you're going to have those molecules. And because of that, they indicate that your body's cholesterol production rate. As you can see, you peek down at mine. I am a hell of a producer. Man, oh man. Ooh, look at that. That is not good. But there is luckily I am on top of this stuff, and we'll talk about that in a bit. But so that's endogenous production. And then in terms of exogenous absorption, dietary cholesterol is absorbed in the intestines along with plant sterols like Beta-sitosterol and Campesterol. Now, these sterols compete with cholesterol for absorption, making their levels indicative of how much dietary cholesterol is being absorbed. In other words, you know that if you're absorbing these things, that you're also absorbing a bunch of cholesterol as well. And so in my case, you can see that, I'm, when it comes to beta-sitosterol, I am sort of borderline on the absorption there too. So I'm a little bit of an absorber there as well. So I kind of got it coming both ways in a way, because, I think a lot of people are not absorbers at all. And I happen to be an absorber, and I happen to be a significant producer as well. I'm a cholesterol machine is what I am. Just going back to the numbers specifically, as you can see in my study, the lathosterol in particular, it's super high. It's, it looks like it's in the, top 15 or 20% of individuals. And so, lathosterol, again, is a precursor in the cholesterol biosynthesis pathway, specifically just before the final conversion to cholesterol. So what does elevated levels of lathosterol suggest? It suggests increased liver production of cholesterol synthesis. And this is, in my study, lathosterol level was, looks like 329 with an absolute value of 3.8. In the red, it is significantly elevated. And again, what does this indicate? A hyperactive cholesterol production pathway, which may be due to genetic factors. And I can tell you a little bit about that. They talk about familial hypercholesteremia. I don't think anybody in my family has super high cholesterol, and it can also happen from insulin resistance. So I'm not insulin resistant. The reason that I started, being really aggressive about my lipids even 10 years ago was the fact that all of my maternal uncles, 3 of them, they all had heart attacks in their early 60s. One of them passed away, like around 60, maybe 64. And my maternal grandfather died of a massive MI in his early 60s as well. So anyway, the point is, like, I've kind of known about this for a long time. And so obviously, I've gotten some of the genetic makeup of these relatives of mine. That's not surprising. I mean, it is what it is. The value this provides me is just confirmation that, statins or Repatha, both of them are my best pathway to decrease my cholesterol. But just in the interest of being complete, you see that my Desmosterol is another, is also sort of in the borderline area. Desmosterol contributes to about 20% of total cholesterol production. So high levels reinforce the diagnosis of increased cholesterol production. Mine is sort of borderline there. It's high normal, I guess. Supports the idea, again, that production is indeed elevated, but it may be it's a little bit more modest than the lathosterol alone would suggest. So as for my absorption markers, so let's talk about those. So beta-sitosterol, what is that? It's a plant sterol absorbed in the intestine that competes with cholesterol. Okay, so in other words, if you're getting a bunch of this stuff in, it means that you tend to absorb dietary cholesterol quite a bit as well. And this is particularly important identifying over-absorbers, which I'm not necessarily an over-absorber here. I'm, my level was, 120, placing it borderline range. It's not excessively high, but again, it is contributing to my overall cholesterol profile. So it is something that, if I want to be very diligent in my cholesterol, I need to know that. And, if I was an over-absorber, in other words, if I was in the red in this category, I would want to be on a medication that stopped me from absorbing a lot of cholesterol. for example, Zetia, right? Ezetimibe. So that's a really important thing here. And just for completeness, it looks like there's actually something where I am in the clear, and that's Campesterol. It's another plant sterol similar in function to beta-sitosterol. Its level, again, reflects the efficiency of cholesterol absorption. Elevated Campesterol indicates increased absorption. Mine, again, was within normal limits, but even so, it was still kind of on the higher end of normal limits. So, but, you know, again, my issue is primarily one of production rather than absorption. The next line here is the cholesterol balance score. The cholesterol balance score is a ratio of production to absorption markers. Okay, so a higher score suggests a predominant role of cholesterol production, while a lower score would indicate absorption as the main issue. Again, my score was 2.4, which is strongly indicative of overproduction as the dominant issue. So again, let's talk about the treatment implications again. We're looking at this in clinical practice. It's common to see patients with either overproduction or overabsorption of cholesterol, but less commonly both, like me, for example. Overproducers constitute a significant portion of patients with hypercholesteremia. So again, it's much more common to be in the category that I am, where you're just, producing like crazy. Overabsorbers, less common. Again, that's a genetically predisposed type of thing. And it's actually kind of easier for people who are overabsorbers because, man, you could avoid, the high cholesterol foods or, just take Zetia and it sort of solves your problem. I shouldn't say it's easier. I would prefer to be an overabsorber. Let's put it that way, because I would rather be on Zetia than a statin. But anyway, they may constitute a smaller group of people, these overabsorbers, but they require... But it's important to identify them because they require different treatment strategies like Zetia. So again, for treatment implications, overproducers, statins are going to be the first-line treatment because they directly inhibit what's called HMG-CoA reductase, and that's the enzyme responsible for early stages of cholesterol synthesis in the liver. Obviously, the other medication that is really useful and it's kind of like the nuclear option for people with high cholesterol is Repatha. And so this is essentially an injection that you get. Essentially what it does is it creates more receptors of LDL at the liver, and it kind of pulls them out of circulation. So that's what Repatha does. And so those two are really good for people who are overproducers. I actually am on Repatha. Until recently, I was on a statin. I may need to go back on that statin now. Although what I will tell you is that even with just the Repatha, my ApoB is about 60. That's pretty good. That's kind of like my general thing, to stay below 60. But what I had done at some point was to change to Zetia before I'd gotten the results of this test to see if I could, keep my levels of cholesterol low if I did that. And it actually went up quite a bit. It went up by about 15 or 20% when I got off of the statin. So the Zetia didn't really help very much, as far as I can tell. And I think mostly the outcome of my cholesterol right now is because of Repatha, probably not because of the Zetia. Now, in some people, like for example, like if I was both a super absorber and I was making cholesterol a lot, I mean, it wouldn't be out of the question to target both pathways and, look at a statin, Repatha, and or Zetia on top of that. Just real quick, going over some of the genetic reasons for these kinds of elevations. For example, in the case of overproduction, cholesterol can result from genetic mutations in the LDL receptor, which is known as PCSK9, which leads to decreased clearance of LDL cholesterol from the bloodstream and subsequent high circulating cholesterol levels. So Repatha is a PCSK9 inhibitor, and net what it does is it makes it so that there are more receptors available at the liver to basically clear LDL from the blood. And again, you can get increased hepatic production of cholesterol from insulin resistance as well. in terms of genetics for cholesterol absorption. One of the things that you can cause that is a genetic polymorphism in the NPC1L1 gene, and that encodes a protein that facilitates cholesterol absorption in the intestines, and that can lead, again, to a greater proportion of dietary cholesterol being absorbed and contributing to higher plasma cholesterol levels. So the last thing I'm going to share with you actually is yet another image, and that is my last couple of draws on blood draws in my lipids. So if you go to the other image there, what you'll see a draw from March of 2024, and then you'll see a blood draw from August of 2024. Now, in March of 2024, I was at that time taking Repatha and pitavastatin, which is one of the statins that is available. Okay, and so when I was on that combination, you can see my ApoB is down at 46. I like it at 46. I feel like I'm suppressing it, to a very significant level. And, I think the fact that I have been doing that for some time is the reason why my recent clearly CT angio was really not alarming at all, despite the fact that I have all of these, genetic, issues in my family with that. Now, if you look at my LDL cholesterol, it was 28, right? And I like it there. I like it below 30. So that's where I was there. Triglycerides were 42. And then what you're looking at for August 5th of 2024, at that point, I had taken myself off of pitavastatin and I put myself on Zetia. This was before I got results of my Boston heart absorption study. And there you can see my ApoB is now 61. You see my HDL cholesterol come down a little bit, and you see my LDL cholesterol is up at 49, which again is not, it's still quite good. And then my triglycerides went up to 71. Again, all of these numbers are quite good, but they aren't as good as before. What I have learned, and the reason I suppress my lipids as much as I do, is that I've spoken now to multiple cardiologists who are very aggressive about lipids, and what they're seeing is that even in patients with clinically significant atherosclerosis, they're actually seeing potential reversals of atherosclerosis. And so that's why I am as aggressive as I am on this. And I alluded to this on the podcast that I did about my Clearly study and CTA. Really, I think, cholesterol isn't everything when it comes to atherosclerosis. It's probably about 70% of the problem, right? You do need to have elevated cholesterol, ApoB, in order to have clinically significant atherosclerosis. It's necessary, but not sufficient. And so that's why you hear some people on some podcasts saying, well, I know this guy with a, LDL cholesterol of, 250, and, he's got a totally clear CT angiogram. And so that makes the complete BS. The cholesterol has nothing to do with atherosclerosis. And what I would tell you is that, I think that is probably the exception rather than the rule. We know that there are other variables that go into atherosclerosis, particularly inflammation, the immune response. And as you may recall, that's something that I like to keep an eye on using the marker HSCRP, high sensitivity CRP. And especially for somebody, who's got a family history of mine on my mother's side, and who is, clearly now an over producer of cholesterol based on this test, it is kind of a no-brainer for me, right? I mean, it's just not that hard to put the story together, that there's a genetic element to my makeup that makes me make cholesterol, more than others, that it is resulting in atherosclerosis in my relatives to the point that they've had myocardial infarctions young and has actually killed, 2 of them in their 60s. So my point is, ignore these numbers at your own peril. I'm not going to ignore them. And, It is a test worth getting, I think. So again, I would, as part of your lipids, make sure you're watching your ApoB. That's critically important. It's not just about LDL, because you can have other small particles that are associated with ApoB. ApoB is the big one. Also remember to test your ApoA, because that is another genetic issue that can really significantly increase your risk for cardiovascular disease. Lastly, consider getting one of these Boston heart tests if it makes sense for you, especially if you have elevated cholesterol. You might want to know if you are an absorber or if you are a producer. Again, it's called the Boston Heart Cholesterol Balance Test. That's it for me this week. Hopefully you enjoyed it. If you're kind of a nerd about this stuff, you probably did. And if you don't like these kinds of details, you probably didn't. So that's it this week for Sapio with Buck Joffrey. This is Buck Joffrey signing off.
Thanks for listening to Sapio with Buck Joffrey. A quick reminder that while I am, in fact, a surgeon, nothing I say should be construed as medical advice. Now, make sure to include your physician in any medical decisions you make. And also, if you're enjoying the show, please make sure to show your support with a like, share, or subscribe. Until next time, this is Buck Joffrey for Sapio with Buck Joffrey.